And Professor Primrose, he was graduate from the University of Glasgow, and now currently he is a professor of surgery in the University of Southampton. And he also involved in a lot of the advisory board, including, I think, one of the important one is the Precision Punk Scientific Advisory Board, and he is a chair. And today he's talking about the role of adjuvant therapy in biliary tract cancer. So please, Dr. Primrose.
I have no disclosures, unfortunately. So, if you're talking about biliary tract cancer, you can either put them all together or you can split them apart. I'm very much in the mode for lumping them together. So, I'm very much. I think you have to put them together. So, despite the fact that they have different disease characteristics, we can't really do studies by splitting them up. Now, in terms of adjuvant treatment, if you go before 2017, really, there's been not any useful trials done that we can use to inform practice. But after 2017, there's several trials have reported. One other, the Japanese trial has completed recruitment, and there's one newer trial in which we are involved ongoing. Yeah, I'll get used to it. So these are the trials. Prodigy 12 is French trial. It's reported. BCAT has reported. I'm going to spend most time on our own trial, BuildCAP. JCOG 1202 is completed recruitment but has not yet reported, and Actica 01 is ongoing. So, Prodigy 12, biliary tract cancer, randomized 1-to-1 to either surveillance or GEMOX therapy. Relapse-free survival was the principal endpoint. And as you can see, there was no significant difference between the arms, although the hazard ratio was somewhat in favor of the active treatment. And I think we would argue there maybe is a small treatment effect here, but this trial was very significantly underpowered. This is a BCAT study, the Japanese study, randomized, the patients randomized between gemcitabine or observation. Interestingly, this group only looked at perihilar and extrahepatics, so excluded intrahepatic cholangiocarcinoma and bile duct cancer. The result, however, was completely unequivocal. There was no benefit in adjuvant gemcitabine. So that basically has killed gemcitabine as an agent in this setting. Now, I want to talk a little bit longer about BuildCAP, as it's our trial. This was looked at the addition of oral capecitabine to curative surgery for all types of biliary cancer. It was developed by the UK NCRI hepatobiliary group, and I was the surgical chief investigator. John Bridgewater, who's sitting here, was the principal medical oncologist on this trial. And this trial, I think, should be published next week in Lancet Oncology, we hope. Basically, patients with biliary tract cancer were randomized to observation or 8 cycles of capecitabine. The inclusion-exclusion criteria, I think, are pretty conventional. I don't really need to go over all of these. The interesting thing is that we have been ran this trial from 2005. So it does sort of illustrate just how long it may take if you're doing an adjuvant trial in an uncommon cancer in a single country, and it really illustrates a need that we need to have international cooperation if we're going to do trials quickly. So we ended up randomizing 447 patients, equally split pretty much into the two arms, and this is the intention to treat population. This is the per protocol analysis population. The difference mainly is 13 patients who didn't actually get capecitabine despite being randomized to it. So this is the intention to treat. Overall survival is a 15-month survival benefit, but this didn't quite achieve statistical significance, although it did after in the sensitivity analysis. In the per protocol analysis, it was clearly significant, with a difference of about 16 months in overall survival. This is the progression-free survival analysis by ITT. This is also positive. The quality of life, interestingly, was not particularly affected by capecitabine treatment, and the quality of life was unimpaired. Now, I want to go over a few exploratory analyses based on this data set, and bear in mind that most of these do not have statistical validity. They are exploratory and really just to maybe open up discussion. So, intrahepatic cholangiocarcinoma, lines appear to separate, whereas in Hyler, that is less obvious or not at all. Gallbladder cancer, the numbers are actually extremely small. We don't see very much of the disease. I suppose you might say for the incidental gallbladder cancers, there isn't much benefit of adjuvant chemotherapy, whereas there may be in de novo, but the numbers really are too small. Extrahepatic, there does seem to be a separation between the lines. This is the resection status. Michael Chotti earlier said you had to get an R1. He's pretty much right. The R1s, sorry. The R1s do much worse, and as you can see, there's not much difference between the treatment and control arms here, whereas in the R0 resections there does seem to be significant benefit. So clearly the message to the surgeons is get an R1 if you can, but of course it can be, particularly in Hyler, it can be impossible. Tumour grade, a busy slide, but just to point out, the poorly differentiated cancers do worse, but the benefit of the adjuvant chemotherapy is highest. And that is statistically borne out. Nodal status, well, lymph nodes are prognostic, but both lymph node positive and negative do seem to benefit from adjuvant treatment. So if we just summarize the results, overall survival by intention to treat negative, but only just. Sensitivity analysis was positive, the overall survival by protocol was positive, and the progression-free survival was positive. So what do we think we know? Well, we think there may be benefit of adjuvant treatment in intrahepatic, extrahepatic, and de novo gallbladder cancer. It may be the benefit is less in perihylar cholangiocarcinoma and incidental gallbladder cancer. R1 resections don't benefit. Node positive patients do benefit, as do node negative patients, and the effect is seen most in poorly differentiated tumours. And just bear in mind, these are exploratory observations. Now, what about, how do we explain the apparent lack of benefit in Hyler disease? Well, the incidence, the incidence of R1 is actually much higher in perihilar disease, and as R1 resections tend to benefit less from chemotherapy, this may be part of the explanation. And it does raise the issue of whether there should be studies now of SBRT, IMRT or SBRT in hilar cholangiocarcinoma that are R1 resections. And that's something that could be considered. Just summarising this along with the other the trials that we have, Prodigy 12, no benefit. BILCAP, we would say the trial has been beneficial. Actica 01 was designed to be cisgem versus observation. However, it has been changed now to capecitabine versus observation. 1202 has finished recruitment, and I'd be interested to hear when the results coming out, but the Japanese BCAP trial is unquestionably negative. So, can conclude that capecitabine as adjuvant improves the overall survival in resected biliary tract cancer for 36 to 51 months, and should therefore be we believe, the standard of care. And despite the fact that the ITT was negative, the totality of the evidence, I think, is sufficient for this to become standard. And indeed, as the ASCO guidelines, which were published just last week, advocate capecitabine as adjuvant in this setting. Now, there is, of course, much to do in the future. While I've said that we had to lump these trials together in order to actually get a successful trial, it's well known now that the molecular pathology of all these tumours are a little bit different. And although in ABC02 they did respond pretty much all to the GEM-CIS regimen, almost certainly there is room for stratification and stratified trials in this disease. So, for the future, will capecitabine be used as standard of care? Well, I think it probably will, and clearly S1 might also feature in there if the 1202 is positive. Will we ever do another trial with a no treatment arm? Really not. I think there's been no appetite to do that. Is it going to be possible to do adjuvant trials on individual sites? Probably there just aren't enough. But if it comes to IMRT, SBRT, yeah, I think there is a place to add these to the conventional chemotherapy adjuvant trials. And as regards molecular stratification, yes, I think almost certainly that even if it's not up front, all of the future trials are going to have tissue collection and molecular analysis to inform the result. So, just finishing, nicely on time, in fact ahead of time, I think. Systemic adjuvant treatment should be used in bile duct cancer, and at present, capecitabine should be used. Although other treatments should be sought, and the Actica 02, which is now examining capecitabine versus GEM-CIS, is actually recruiting extremely well, and a result from that we should get out in a year or two. It does show the advantage of doing much larger international trials. Actica 02 covers Europe and Australasia, and certainly should get a result much quicker than BILCAP did. And future trials will probably need to include some form of SBRT in certain settings as neoadjuvant. So we couldn't have done the trial without the support. Both BILCAP and NACTICO-1, certainly in the UK, are funded by Cancer Research UK. Thank you very much.
Thanks for your excellent talk, and now the talk is open for question.
John, thank you. That was a wonderful talk. At the conclusion, do you think future trials should still lump or should they split?
I think I'm a lumper. I mean, I think the only thing you can I mean, I think lumping with stratification is, I think, the best way to do it, really, isn't it? Because they're just, even with a big international trial, the stats just don't yet work out. So lump, yes, but stratify by disease site, and I think that's going to give you the most information. The pedants will always say you can't do that, and I get every time I talk to this before an Indian audience, I always get slated for including gallbladder cancer, because that's regarded as a completely different disease. But they're all completely different diseases, and why take out gallbladder and not intrahepatic? So it becomes a difficult argument. So just stick them all together and see what comes out of the wash.
Yes, please.
I have a question in terms of future trial design. You mentioned that in future trials, adjuvant CAPE should be the standard for the control arm. So if that's the case, how are we going to ever, if we do preoperative therapy trials, or if we're trying to test a perioperative regimen against resection versus adjuvant, if adjuvant always has to be CAPE in the postoperative setting, how are we going to ever test a perioperative strategy?
Well, I would argue, and clearly we've discussed this, that if everybody's getting the same, it doesn't matter. I mean, it's what would be more difficult is if you started to change the adjuvant halfway through the trial, and I think that would be difficult. But it seems to me that if you're, as in the trials we've discussed, giving chemotherapy up front and then them having a different adjuvant, I think that I don't see a problem with that, as long as every patient's treated the same. Some may argue, but I think that's the only pragmatic way of doing it. Yeah, with a 16-month improvement in overall survival for adjuvant, it's quite a large effect, and it'd be very difficult to say to a patient you can't have that. Particularly in your preoperative chemotherapy, there will be an observation arm. So I think it's a compromise. It's reasonable.
Yeah. Professor Chan?
Yes.
Hello. Can I ask Dr. Primrose? Thank you very much for the presentation.
Oh,
I'm sorry.
Sorry. I was looking at the outside. You can't tell where it's coming from.
I'm sorry. Get back to the BILCAP trial.
Yeah.
I think that BILCAP trial is really a phenomenon in the field of the BTC, because that's really brings some hope for patients who have received the resections. But if you look at, try to look back purely from the trial design point of views, and because the primary endpoint is actually not met, can I say so? Because the ITT over survival actually did not meet the statistical significance.
We've never said anything different. Yeah, that's right. Not by far. And just to say, there was a pre-planned sensitivity analysis to take account of prognostic factors, and with that, it was clearly positive. But if you're going to be a purist rather than a pragmatist, you say the ITT OS endpoint isn't met. But what I say to people when they bring this up at a meeting is, well, what would you have? I've never found anyone who said they wouldn't have it.